Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director at Healthcare Improvement Scotland. And welcome to you all to this, the 7th in our exciting lineup of QI Connect WEBEX sessions for 2015. This is the 17th since we began in 2014, and you're very welcome. This series came from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to be accessed at a later time if that suited them. As you can tell, we're live today. There goes an ambulance right past the office. But welcome to QI Connect. QI Connect is now reaching a whole series of organisations across the world. However, before we go to that, let's go to Jennifer, who's going to tell us a little bit more about using WebEx. Good afternoon, Jennifer.
Thank you, Brian, and good afternoon to everyone on the session today. So just a couple of housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of the screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or call the number, or press *0 on your cell phone. So on the right-hand side of your screen, you should be able to just see a list of everyone who has joined the call. If you wish to make a comment or join the conversation, please type into the chat box circled there, and please select all participants from the drop-down list circled red on this slide, type your message and then send. And we do want the session today to be really interactive, so please do keep your comments and questions coming throughout the talk. So here's the first of our fun interactive parts of the session. So we're really keen to see where everyone's joining us from today. So if you're able to just click on the arrow icon in the top left-hand corner of your screen circled on this slide, and then just click on the map to show us where you're dialing in from today. Fantastic, that's great. So welcome to everyone on the session. There's still a few more coming. And I'm just going to hand you back over to Brian, who's just going to give you some background about the series and the organisations that are linking in.
Great. Well, welcome everyone. Wonderful to see the United Kingdom and other parts of the world lighting up there. And a particular welcome to David Grayson over in New Zealand. Kia ora, David. So we now have more than 290 organisations connecting in to QI Connect. When we started this series last year, we had one page of images of those organisations. We're now looking at 9 pages of images. So welcome to all of our friends and colleagues across the world. Before we come to that, we are delighted to say that we've now got more than 40 countries across the world who link in either directly or indirectly to the QI Connect series. And we've got a little competition for you. So again, Jennifer's taught you a little bit about using the arrow. I'm going to name a country, and I would like you to put your arrow on that country's flag, which is on the screen just now. And when that flag, the first person to get that flag gets a wonderful prize that I'll tell you about just in a moment. So the country, oh, there's someone guessing already. The country we'd like you to tell us a little bit, or put your marker on the flag, is Singapore. Okay, you're all trying, but you're not quite there just yet. Kerry McClure. Well done, Kerry. Yeah, and a close second to the rest of the folks there. So, Kerry, we're delighted to say that the wonderful prize you'll get is a QI Connect mug. I know you can hardly wait, and you'll enjoy that. So, congratulations to Kerry. Excellent, good. So, as I mentioned, we've got more than 290 organisations that sign up for QI Connect, and here are just some of those. Previously, as I said, it was just one slide of images, and now we're looking at more than 9 slides of images. And we're absolutely delighted to welcome you to the series, and thank you for your contribution. We'll look forward to hearing from you in the chat box as we go through. And also, I would just like to call out, as always, our special mention to our university colleagues who both dial in live and also use the QI Connect series in classes, the recordings in classes. And a big shout out to 3 new universities, the Galway Mayo Institute of Technology, the Abertay University, and Robert Gordon's University in Aberdeen, which brings our number of universities to 26. So you're all very welcome indeed. And a special mention to some new folks that are joining us today for the first time, and particularly to all of these colleagues, welcome to the series. Big shout out to our friends here in the west of Scotland at the Beatson Cancer Centre, and to our friends elsewhere across the world. Welcome to the series. We're also delighted, as I've mentioned, that many organisations use the QI Connect materials for their own learning after the event. And so just to remind everyone that the call today and all of the chat is recorded and will be made available to everyone shortly afterwards. We're also delighted, of course, to have ISQA as a partner and the International Society for Quality in Healthcare. They use the QI Connect series in their ISQA fellowship program. So a big shout out to them, and thank you for continuing to support our work. Also a big thank you to the small but perfectly formed QI Connect team with Jennifer Graham, who you've heard from earlier, with Carmen, who deals with all of your administration and sign up and your certificates of attendance afterwards, and for Ross, who provides data analytics and project support and is with us here in the studio today. And also a big shout out to Michelle Miller, who's joining us this afternoon. Michelle is the National Improvement Lead for Dementia in the Scottish Government, and one of our long-term friends and colleagues here in Healthcare Improvement Scotland, and we'll look forward to hearing from Michelle a bit later on in the call. And so that brings us to reminding you that we are trying to be bigger and spread our word through Twitter. So we're at #HISQIConnect, and you can follow us at HISQIConnect. So please tweet as we go through. We're really keen to spread the message both about what you're hearing today and also about the use of the recordings. And that brings me to introduce our first speaker today. Our speaker will be very well known to many of you, as she has a long-standing and deep relationship with Scotland and has inspired us in our efforts to improve care across our nation. Our speaker started her career as a frontline nurse and has never forgotten her experiences in that role, and to this day spends as much time with health and care workers at their place of work as possible. She is, of course, Maureen Bisognano, the President and Chief Executive Officer of the Institute for Healthcare Improvement. And we're absolutely delighted to have Maureen with us today. Good afternoon, Maureen.
Thank you, Brian, and I'm absolutely delighted to be with you. It's a pleasure to have this opportunity to be talking to you all a little bit about some of IHI's work, but also to be sharing with you some examples of the kind of work that we're doing around the world. So I look forward to this time, and please do, as Brian said, chat in your questions or your observations, your ideas, because our motto here at IHI is all teach, all learn, and I'm hoping to learn as much as I share with you this afternoon. So I thought I'd talk today a little bit about the journey that we're taking at IHI, and it really is moving from improving healthcare to also improving health. The mission that we've got here at IHI in Cambridge, Massachusetts in the U.S. is to improve health and healthcare worldwide. And our vision is that everyone has the best care and health possible. So the way that we think about this is that we've got to move upstream a bit and start to think in a new way about our work in healthcare. You'll see here on the slide, this is IHI's strategy on one page. And in the early days of IHI, most of our work was in that top blue circle on the left. It was about accelerating the pace of improvement in healthcare. And we mostly were looking at safety and access and flow, person and family-centered care. But we realized quickly that as good as we were getting at healthcare, we weren't really impacting health, and that was the true end game. So we added the second blue circle at the top and said not only do we need to continue to accelerate the pace of improvement in healthcare, and we need to innovate and partner with organizations to improve health. And so I want to just give you a couple of examples of our work in both areas so that you get a sense that we're not done yet with the journey of improving healthcare, but we have lots of hope and optimism about improving health. If we start with the Triple Aim, and this is where I think most people are in healthcare today, when we started the idea of the Triple Aim back in 2007, we went around and asked people, where do you see yourself? And people sorted themselves quite clearly. Either I'm a population health or a public health person, or in the bottom left, I'm working on the experience of care. I'm a physician or a nurse or an administrator providing care, or I'm in the finance area. But we found few people who identified themselves in the middle. So we put that little blue dot in the middle to say we think it's all of our jobs to come in and work together on the Triple Aim, and that's what I want to share with you this afternoon. This year in 2006, in October 6th of 2014, we launched a new leadership alliance, and this is about the circle on the left. This is about improving health care. We started in the United States, but we're hoping to expand this outside the U.S. this year in 2015. And what we did was we called upon pioneering organizations to come together and say, we're going to transform healthcare ourselves. We're healthcare leaders. We're going to take the responsibility. We're not going to wait for government or policy, insurance companies or payers. We're going to step in, and we're the ones that know best what patients and families need. We're going to transform healthcare. It's been a really interesting experience. We have 4 parts to this journey. The first one is redesigning measurement, and Elliot Fisher, who's the founder of Accountable Care Organizations here in the United States, is our lead on redesigning measurement so that it's meaningful and useful and not overburdening the staff that are trying to provide care. The second piece is a piece that's being led by Don Berwick, the former CEO of IHI, and this is about radical redesign. I'll come back to that in just a moment. The third piece is about leadership and joy in work. What is it like to lead in today's very complicated healthcare organizations with multi-professional teams, multi-generational staff, and a hugely quick pace of change? And I'm leading that work. And then finally, the fourth strategy is collective voice. If we all say the same thing together, we believe we can accelerate the pace of change. But let me come back to Don Berwick's piece, and that is radical redesign of the care systems and processes. What we did was create a list of radical redesign principles that we're using to prompt conversations with healthcare leaders around the country. And I can tell you it's an amazing thing when you provoke people with these kind of principles. Cultivate joy in work. We're taking a deep look at that, making it easy. I want to talk a little bit about moving knowledge, not people, and give you an example of some work we're partnering with today. One of the things that we're doing is we're working on a project that began with a physician in New Mexico. His name is Sanjeev Arora, and he was the only hepatitis C physician in the state of New Mexico, so that everybody who needed care for that particular devastating disease would have to travel to the University of New Mexico, the academic medical center. They would often have to wait months because he was the only physician in the state qualified to care for those patients. And then the patients often had to drive 200 to 300 miles to visit him. When they returned to their home primary care sites, they were working with a primary care team that knew nothing about the specialized care they were receiving at the university. So Sanjeev came up with an idea. Maybe he should move knowledge, not people. And this picture here, that's Sanjeev sitting under the E with the tie, the suit and tie on. He now is providing care by not doing telemedicine, but doing teleteaching and teleconsulting. So you can see him there on a Monday morning in his office with very inexpensive video conferencing, and he's connected up to primary care practices around the United States. What he's doing is using case studies to present best practices in caring for patients. And so a primary care physician might have a particularly challenging patient. They'll present the case study, and he'll walk through the best clinical care for that particular patient. So what he's doing is through teaching and case studies, through coaching and consulting, he's equipping people all over first the state of New Mexico, then the country, to provide best care for this complicated disease. Look at this. The treatment outcomes for Project ECHO are actually better than the care he was able to provide one-on-one at the University of New Mexico. So we're seeing better care and, of course, much better patient satisfaction. They're not having to drive and sit wait for months for an appointment. The primary care doctors love it. I could go on and on about the clinical outcomes. But the physicians are saying that they feel so confident now in caring for these patients, and they're able to put all the pieces together, not just the medications, but how do we think about the whole patient's journey? And the cost is, of course, much, much cheaper when you do it this way. So Sanjeev started to reach New Mexico and then the country. And recently, I partnered with Sanjeev to start teaching primary care clinics, neighborhood health centers across the United States, how to improve access and flow, and how to build improvement capability. I do believe this is going to be the future of specialized knowledge and transfer. So Sanjeev then went from himself treating hepatitis on Monday mornings, he added a rheumatology specialist on Monday mornings and started working with people for HIV, integrated addictions and psychiatry, working with peer groups in prisons, and we're seeing all this kind of amazing care that's being delivered through consultation, teleconsultation, and teleteaching. It's the Triple Aim: better health for these populations, much better care experiences at a much lower cost. So Sanjeev and I are now collaborating on how can we work around the world to reach billions of people, because I do see that this notion of moving knowledge, not people, is really got tremendous traction for the future. The second project I wanted to talk a little bit about is another project we launched in October 2014. Again, launched it in the United States, but have plans to spread it in 2015 around the world. And that's a project called 100 Million Healthier Lives. Here, we want to get 1 out of 3 in the beginning, people who live in the United States, to be living totally different and healthier lives. So we brought together people from around the country, and it certainly was not just healthcare providers. We had people from public health, and we had school teachers, and much like the Early Years Project in Scotland, assembled everybody who cared about health. And they came together at IHI for several days, and we started brainstorming about what might a totally different way to think about health look like. We created a guiding coalition. We have now almost 500 organizations across the United States in just 9 months' time actively working on thinking about health in a different way. One example is in Pueblo, Colorado, where they actually named a corporation. We're going to call ourselves the Triple Aim Group, and we're coming together to think about reducing unwanted pregnancies in teenagers. We're looking at lowering obesity rates. We're working on especially working with vulnerable populations to help them quit smoking and improving the lives of frail elders. And you can see from this graph here that in a few years' time, the folks in Pueblo have already decreased unintended pregnancy, and they're now using that same kind of community coalition to spread these ideas even further. In Monadnock, another community here closer in New England, they're looking at equity. How do they understand where there's inequity or disparities in clinical outcomes? Is it an access problem? People who are poor can't access the health system? Or is it a different set of factors? They can't afford healthy food. They're not living in homes without mold or other factors that affect their health. And they're looking at the built environment. So we're here, totally different conversations. People in the past told us that they used to meet, but they weren't acting, and now they're acting. And I think that's been the really powerful thing about working on this at a community level. So what I'm suggesting here is that I think we need a couple of big changes in order to get to the Triple Aim to work on not only healthcare but health. The first is new roles, thinking about new roles because the traditional folks are still being trained largely in the old way. So how do we break through and think about new roles, then think about new sites of care, and think about new teams? New roles. I'll just throw out a couple of ideas. Last week, I had a wonderful conversation here at IHI with a physician named Rishi Manchandra, who has created the idea that we need a new specialty, and he calls it upstreamists, that we need to have people whose job it is to think upstream, and that every one of us in a care setting needs to think about our role as thinking about upstream. How not only do we take the best care of somebody with diabetes, but how do we prevent it? How do we prevent the complications from CHF? How do we stop obesity? And so that notion of thinking upstream is, I think, a very powerful one for me. A second one is extensivist. How do we not discharge or hand over patients from one setting of care to another, but how do we actually think about taking care of patients across the continuum? Again, had a wonderful meeting at IHI this week with a group of people who take care of children with severe chronic diseases. And the conversation was, how do we not hand them over when the young child turns 21, but how do we provide a care team that actually takes care of a child through their whole life so that they don't have to endure the burden of a handover, but we create vital teams that know how to care for people at all ages. And third, we're seeing wonderful examples of paramedic teams that are not only responding to emergencies, but they're actually creating health in their communities. We're seeing around the world paramedic teams that are actively going out and visiting people who they know are living alone, who might stop and pick up medications from the pharmacy to assure that a patient who doesn't have transportation has access to medications. We're looking at paramedic teams that will go visit an elderly person who's frail, not to assess them and not to transport them to a hospital or to a physician practice, but just how to keep them company and looking at all of the social determinants of health. So I think we need to think about new roles, and I think we need to think about new sites. And I just want to give you a couple of examples of new sites of care to provoke our thinking for the rest of the conversation. The first one is home. And here we're seeing, again, many elderly people are starting to use technology to connect with their physicians and their primary care teams to get care at home. At first, when we were asking clinicians, pharmacists, and physicians, can the elderly use technology to connect with you? And the assumption was no, that they won't. But this gentleman is a perfect example. What we're finding is that giving the elderly an iPad and using that to help them connect is producing almost daily short interactions with the healthcare system that are much more effective than waiting for a 6-month visit. What you're seeing here is a person who's doing medication reconciliation with his pharmacist. And so what the tension about on the clinician side was, oh, they won't be able to use the technology, and boy, have we been proven wrong. They love it. They set up an appointment, they get dressed and get coffee, and the women put a lipstick on. It's a social event for these people to connect with somebody on their iPad, do FaceTime. They bring all of their medications and line them up. And what we're finding is that there'll be a pill bottle or an empty spot on their pill box. And the questions that are asking are producing much higher reliability assessment of what the patients are actually doing and what kind of adherence rates we're seeing. Another place is at the workplace. And this is an example from Bellin Health. Bellin Health looked at the health of their employees in the first instance. And I don't know about the countries that you're all working in, but here in the United States, people who are working in healthcare are among the least healthy of our nation's residents. So I do think we need to start here. We need to start in healthcare to make people who work in healthcare healthy. At Bellin Health, they agreed, and they began with their staff. And what they're finding is that by focusing on their employees, they were able to increase they were able to actually save a lot of money because they were going upstream, and they were looking at improving their health risk appraisal scores as the people got healthier because they were accessing upstream care more than downstream care. The cost came down. And what you're seeing is the number of people who are at high risk, the number of high-risk employees dropping dramatically. Once their workforce became healthy, then Bellin said, we're going to go out and start to work with all of the other employers in our region. Now imagine the power of the CEO, George Kerwin from Bellin, being able to go out to employers and say, this is how healthy my workforce is. Let me help you with this. And he's began to put clinics and on-site services into the major employers around his hospital in Green Bay, Wisconsin. And now all of a sudden the employers are seeing their employees, because they're getting care at the site of work, become healthier and the costs are reducing. You probably have all heard about the latest trend in the U.S., which is accountable care organizations. George started with his employees, went to other employers, and then was able to launch an accountable care organization that by all measures in the United States is the most successful accountable care organization in the U.S. They're seeing the quickest rates of improvement in health and the fastest fall in costs. So here he's saying, let's start internally and then move externally and building up the momentum for change. He's now moving from accountable care organizations to the community and beginning to partner with other county systems, with schools. He's got healthcare people in schools. He's got healthcare people out in the churches. And what they're starting to see is huge momentum in the 100 Million Healthier Lives campaign to move health into the community. But I do think it's a wonderful example of starting inside and then moving out. Another example of an employer-based workforce health initiative is a new company that's called the Wonderful Company. And I love this company. It was started by two very successful entrepreneurs who began to think that their job wasn't just about being successful business people, but it was about health. So this Wonderful Company started buying up all of the food production systems in the western part of the U.S. that produce healthy food in a healthy way. So they're producing fruits and vegetables, almonds, and the like in the healthiest way. What they found is that they have 8,000 employees, and most of them are immigrants from Mexico. And as they found that when they came up to the United States, their health wasn't great, or they didn't have great access to the healthcare system in the United States through the normal methods. So the Wonderful Company is working not only to produce healthy food for everybody in the U.S., but to make their workers the healthiest people in the country. So I love this idea of thinking about us as employers producing health inside our own companies first. Another great place to think about producing health is schools. And I want to show you this example from Chile. We were partnering with some folks from the Harvard School of Public Health on working on improving the health of children in some of the schools in Chile. And in the early days, what the doctors and nurses that we spoke with said is, we only see these children for maybe 15 minutes twice a year. There's no impact that we can have on childhood obesity. And so we said, well, if the children aren't at the physician's offices, where are they? Maybe they're at school, so let's go into the schools. What we found, though, is that they weren't regularly attending schools. The absentee rates were really high. So the first project that we did was to decrease chronic absenteeism, and we're using a driver diagram. I'm sure you're all familiar with this tool to decrease absenteeism by 20%. Our theory was that the primary drivers were going to need to focus on the children and also to focus on the parents and then to focus on the teachers and the leaders, the principals in the schools. So this is the focus for the parents. This is a big whiteboard. When you walk into the school, it's in the front hallway. And at the bottom of each one of these columns is the child's name for a particular class. And then each day when they come into school, they get a red dot, and they put that on the column with their name. What we found was that the parents coming in had no idea of the variation in absenteeism or presenteeism of their own child. So it was motivational for the parents to try and close that absentee gap as much as it was for the children. The children also get motivation. You can see here that they get crowns and prizes when they have exceptional attendance, and they get certificates that demonstrate the gratitude of everybody to be there in school. And then the report cards are actually going to the school teachers now. So we're measuring absenteeism, and the teachers and the principals are looking at absenteeism through a different way. Once we got the children in school, we could start to work on obesity. And the first PDSA cycles were about decreasing sugar-sweetened beverages and increasing water consumption. You can see here the PDSA cycles. The first was just making water available, and the second one was about banning sugar-sweetened beverages and not allowing them in school. The third one was about developing a measurement system for the kids, and this is what it looks like. Every child has their picture in a shape, and it's on a wooden dowel. And as they drink water throughout the day, they're raising their picture to the top of the dowel. So we've not only taught the teachers PDSAs, we've also taught the kids how to improve their own health by giving them methods and tools, improvement tools, so that they increase their water consumption and move their picture up to the top of the dowel each day. The fourth one was changing what they served in the cafeteria. My favorite, I guess, is that every teacher has 3 plants on her desk, and each morning she pours water into one, pours nothing into the second one, and pours Coca-Cola into the third one. And what you can see is 2 of the plants dying and 1 thriving. And as the kids are watching this, you can see that the sugar-sweetened beverages have been decreasing as water consumption is increasing. So it's just an example of how I think us in healthcare, we could never have accomplished this alone. But I do think that by sharing our tools and methods, by looking at school as a place for improvement, for health, we can actually make some really dramatic changes. The next one is churches, and we've got a wonderful example here in Memphis, Tennessee, of a church health clinic that is focused on people who have challenges in getting access to care. This church health center built a clinic and brings people in not only to provide health care, but to stimulate health. And they're open to accessing health needs for anybody, but I love what they're particularly doing on the focus of health. So they provide health care in the normal kind of a clinical setting, but they provide health by having a wonderful gym, by encouraging healthy cooking and healthy eating, and by focusing on a school, by getting students in and having people volunteer to teach these kids. And what they're seeing there is a 74% increase in the mastery of their academic skills by creating this focus on health and learning, all through the church in Memphis, Tennessee. And then lastly, I wanted to talk about new teams. And this one is from Scotland. I think that some of you may know this story, but some years ago, IHI partnered with leaders in Scotland to develop a project called the Early Years. It was a vision of Derek Feely when he was there to create a sense of health from conception to 5 in the earliest times. And we began by partnering with the leaders in Scotland to teach improvement skills so that people could focus on improving health and resilience. And I love this example from Scotland. Elaine Wiley is just a true hero, I think, a teacher at St. Ninian School in Stirling who learned her improvement skills in the early years project and then was provoked by this dear school friend, an elderly gentleman, 81 years old, who has lots of other things to do in his life but finds time every week to go visit the school and to teach the children poetry and music. And one day this school friend was telling Elaine how he was observing that the kids were fat, the kids were overweight, and he didn't think the kids were in shape. So Elaine, knowing improvement skills, began to wonder how could she run a PDSA, and she got some of the kids to run around the field a few times, and I had to get Derek to translate for me what this meant. They couldn't run the length of themselves, that they were running only at a scout's pace, and what Elaine realized is that it was true that the kids weren't fit. So she started to use improvement skills, and she figured out that if they ran around the school on the field 5 times, 5 laps would equal a mile. So she started small, as we often do, got a small group of kids in one class, and they began to run a few times around the school, and then she developed a measurement system and figured out how she could spread this particular model. Here you can see Elaine's PDSA. She began in one class and then eventually spread it to the entire school. And she has the children now going out in almost every single weather, almost every single day. Think about this. It's 15 minutes out of the class day. They don't change into exercise clothes. No training for the teachers. It's simple and it's free. So this one teacher began to develop the daily mile, and this child has got her own measurement system. So she's got little blocks, and as she runs around the track, she adds a block on. So she's creating her own way to track that she's made the daily mile. The parents are saying that the kids are eating better and they're sleeping better, and as often is the case, the children are now provoking change in the parents because the parents now are running the daily mile, so they're getting more fit. And the staff are saying that the kids' confidence has increased, that their focus in school is improved, that they're really ready to learn when they come back into the classroom, and they're developing new relationships that they never did before. So the outcome is there's not one child in this school now that's overweight or unfit. Again, I think Elaine has had a greater impact on health than anybody in healthcare could have had by using quality improvement and by us thinking about a bigger team. So another quick example, and then I'll wrap up for questions, is family health teams in Brazil. And I'm on my way down there next week, and what we're seeing there is a new way to structure healthcare teams. The family health teams have a physician, a nurse, a medical technician, and 6 community health workers, and each team is assigned 1,000 families, and they are not only, again, providing health care, but they're providing health. They're going into every single one of these families' homes every several months. They're looking at food availability. They're looking at weight and exercise. They're looking at family relationships and stress in interpersonal communications. They're looking at are people working or not, and they're providing health care. So I think the more that we can begin to come into the middle of this triangle and begin to think about not only health and care, but how do we come together to reduce per capita cost and think about working in the middle of this notion of the Triple Aim, I think the faster progress we'll get. So thank you all for your time this morning, and I'll turn it over to Brian and Jennifer for some questions.
Thank you so much, Maureen. I'll tell you what, the chat box has never been so sparky and never been so active. We're dizzy catching up on it. But that was a wonderful talk and very relevant to what's happening here in Scotland and by the chat box, what's happening all over the world. So let me just reintroduce Michelle. Welcome, Michelle.
Thank you.
And Michelle, you have a question for Maureen.
Yeah, Maureen, I just wanted to ask you a bit about quality improvement language. So within Focus on Dementia as one programme that we're running in Scotland, we're working very much across health and social care. And I think one of the challenges of working through, across different sectors is often different language used and the direct transfer of quality improvement language between settings. So I just wanted to ask you, how important do you think it is in getting to a shared language across sectors for quality improvement, or do you think it's more important to have a shared understanding?
Oh, Michelle, it's a great question, and I do think language is critically important. What we found is in working outside of the healthcare system when we started moving to bringing people together from various parts of the community, is in the early meetings there was a failure to understand each other. And so we actually, in our most recent work, in 100 Million Healthier Lives, have stopped to bring people together and begin to talk through the lens or through the picture of a patient, how all of these pieces come together. I think language is perhaps just as important as understanding, and I don't think we're able to get to understanding until we share a common language. We just, in the project 100 Million Healthier Lives, launched a kind of a 5-day learning system where we brought people together from all parts of the community. And we actually went back and used kind of games to teach quality improvement so that there was a basic fundamental understanding of what we were talking about. What is a PDSA cycle, and what do the situations that you see look like? And I recently had the opportunity to talk to a wonderful physician in Florida who was partnering with other people in her community, and she went with a sheriff, the head of the police department, into a neighborhood where they were seeing all kinds of problems, and they were looking at the same thing. They were looking at a door that was kicked in, they were looking at broken windows, and they were looking at a little bit of blood on some steps. And the doctor said, "I see domestic violence," and the sheriff, the policeman, said, "I see vandalism." And what we found is that when you ask people to look at the same thing and they see something totally different, that it really helps to create a common language in order to move forward.
Thanks, Maureen, and I really like how the patient focus is so key, and I think that is what has bonded us together through the dementia work. So thank you for sharing that.
Thanks very much, Michelle, and thanks, Maureen, for that. Maureen, many of the points that you raised during your presentation have sparked conversation in the chat box, and delighted to see Tom Houston, the lead officer from Forth Valley, which includes the area where the Daily Mile came from. And thanks, Tom, for flagging up that started with the work locally with the Commonwealth Games that were in Scotland last year. So nice to see that connection. Thanks for connecting in. We have a question here. Welcome to Jill Vickerman from the British Medical Association here in Scotland, and previously the lead at the Quality Unit in Scottish Government. Welcome, Jill. Jill asks, has Maureen come across the problem that clinicians working in very stressed and stretched environments have a real problem about talking about improvement? Does she have any advice on how to introduce this concept when all they want to do is sustain?
Every day, Jill. Every day I come across that. A couple of tools that I've used is, one thing is I found a lot of traction when especially clinical teams begin to use huddles so that they come together on a common framework. And the agenda that I'm recommending for these huddles, it could be daily if you're working on a particular unit, or it could be weekly if you're working on a service, or monthly if you're bringing specialists together. But the agenda that I'm recommending is 3 parts. The first one is innovation, and that is to really focus your innovation energies on perhaps one area where the gap is big, and get everybody's agreement that this is the thing we're going to innovate on. And then getting a small team together with permission to go outside and to look outside for ideas is really empowering and encouraging. The second point I would make is about spread. And I notice a number of items in the chat column relate to this. It is how do you close the gaps between one unit and another, one hospital and another, one team and another. And that's a separate model. But the third one that I have found most helpful is what I call exnovation. So there is innovation, but there's also needs to be exnovation. And exnovation is a process that you use to eliminate the things that we do every day that add no value to our lives. And I think good leaders exnovate. They go in and look at meetings, they look at reports, they look at work, documentation, or processes that add no value to anybody's life. We're doing them out of habit. I think in healthcare we're really good at innovating and we're really bad at exnovating. So I would encourage you to think about that. I can tell you from personal experience, when leaders take the time to exnovate, they create not only time for people, but joy, and that allows them to get in and focus on the work of spread.
Thank you very much for that. We love that exnovation. Many of the folks on the chat were really interested in your comments or your example using FaceTime, and Karen Nathan, midwifery champion from NHS Lothian, was saying that she's doing some online clinics for breastfeeding, which are going very well. And also we have colleagues in Dumfries and Galloway's testing out support for meals for patients with eating disorders using technology as well. So thanks for sharing that. And that might bring us to Elaine Mead's question. So Elaine, welcome, a regular participant in QI Connect. Elaine's the Chief Executive of NHS Highland here in Scotland. And she says, thanks very much, Maureen. We often hear these inspirational stories about individuals working in improvement and making a real difference. But how do we effectively spread these initiatives so that we don't have to keep reinventing and relearning the same things?
What a great question, Elaine. And Elaine is one of my heroes. She's a pioneer in improvement across Scotland, but we also use her examples in the U.S., so thank you. I think the challenge of spread is it's a complicated one. But I think the first thing is when I go into a healthcare organization, I will ask them 4 questions, and they're intended around driving people to spread. But let me share the 4 questions with you. The first one is, do you know how good you are? And that question is intended to provoke the senior leaders or the leadership team to ask themselves, what data do we look at? How often? Not only do we look at data quarterly or annually or monthly, that's all looking back, but how do we know today how good we are? And that is, what do the leaders do on a daily basis to hear the voice of a patient or a family member, to understand what staff are going through? And so that question, do you know how good you are, is a provocative one for many. The second question is, do you know where you stand relative to the best? And I think this gets at your point, Elaine, that we often hear these examples of exemplary performance or wonderful innovation, but most people don't look at it relative to themselves. They may not take the data back from the Chile project and say, are we motivating kids to actually lose weight? Or how do we take a look at the exercise capacity of the kids in the school in my community? So do you know where you stand relative to the best provokes people, because most people don't. Most teams don't. They look at their own data and only their own data. But that gap provokes people. The third is, do you know where your variation exists? And most people don't. They look at averages. They look at how the average infection rates on a unit or the average waiting time in an A&E department. But I think that looking at the variation provokes change, because you see the gaps between the best performers and the worst, and that's going to provoke leaders to change. And the last is, do you know your rate of improvement over time? And most people overestimate their rates in my experience. So I think when you provoke a team with the answers to those questions, it will compel you to then exnovate so that you can free up some time. And then assign people, go visit the best, go understand the variation with the specific idea that their job is to close that gap. There's a hospital here in the United States called UPMC, University of Pittsburgh Medical Center, and what they do is every summer when the census goes down, they close one unit, one medical surgical unit, and they reopen it as an innovation unit. They assign fewer patients to that unit, and they have a random sample of nurse manager, pharmacist, and staff that work on that unit. With the lower caseload, their job is to innovate to solve chronic problems. And they've done everything from decreased delays in getting a patient admitted to reducing medication errors. But what they do to spread is they keep the unit open for 6 weeks, and they have that 6 weeks to create a model that demonstrates improved care in the unit. And then that team goes from unit to unit to unit to assure that every other unit in the hospital and then in the system gets their performance up to the same level that they were able to produce in the summer experiment. So they create this internal spread team that closes that gap. And so any kind of a method like that, Elaine, might be helpful in spread.
Thank you very much for that, Maureen. A nice comprehensive outline there. Again, the chat's a lot of chat about the example that you shared about the kids in the school with the 3 plants and the Coca-Cola plant. I'm delighted to welcome Scotland's Chief Dental Officer, Margie Taylor, to the call today. And Margie's thinking she might roll this out across dental clinics across Scotland. So good job. Thanks very much for that.
I love it.
Now, we have a question from Gavin Lavery, who's the Clinical Director of the Health and Social Care Safety Forum in Northern Ireland. Welcome to the call, Gavin. Gavin's asking, he says, many of the examples are showing quality improvement moving into areas that have been the province of health promotion or health improvement. Have you seen systems where this has resulted in any difficulties? Do you see this approach replacing standard ways of promoting wellness?
Well, it's a great question, Gavin, and hello, it's been a while. I do think in the early days we did see a lot of problems. I would say that some years ago, about 8 or 9 years ago, Don Berwick and I convened a group of people who worked in public health, people who worked in health promotion at IHI, and we didn't speak the same language. We were trying to provoke them to develop an institute for public health improvement. It was before the Triple Aim and before we saw that dot in the middle of the Triple Aim, and we were just thinking, could we provoke them to think in a different way? And I will say we didn't speak the same language. I see something very different right now, and I see people coming together. When you look at a problem like obesity, or you look at a problem, I'm always talking about the burden of the illness. And if we look at the burden of the illness in our societies today, it's increasing so quickly and so dramatically that I think people are much more willing to come together and say, we need to reduce the burden of the treatment so that we can produce better health together. So I'm probably as optimistic as I've ever been that all these people in the communities, people who have been working on promotion or public health, are in a great place to come together with healthcare providers.
Super, and Amelia Crichton's on the call from the Faculty of Public Health, so I'm sure that will be music to her ears. She also loved the idea of upstreamers earlier in the comments today. We've got the IT piece really stimulated some debate and some comments, but we've got a question here from Andrew Manchip, who's one of our reviewers of death certification here in Healthcare Improvement Scotland. And basically Andrew's asking, how about the costs of IT? Does this work out financially? Does it make sense to be using IT the way that some of the examples have?
Well, so that's a great question. What we're seeing is that, first of all, even here in Harvard Square in Boston, there are a number of new startups that are producing apps for your phone. Most everybody here, and most everybody even in many developing countries, are using cell phone technology. So the cell phone technology itself is not costing anything more, and these apps are increasingly free, and they're ways for physician practices to keep connected to their patients. What we're starting to see, again, to go back to some of the radical redesign principles, is that physicians or practices in the old days perhaps used to have everybody having a 15-minute visit or a 10-minute visit. and it didn't really separate out patients who had really severe chronic disease from ones who just needed a quick answer to a question. So what we're seeing now is redesign that says that if you have let's say a child with severe chronic illness, that person might get an appointment that lasts 45 minutes or even an hour, and it might be a team that comes together. Physician, nurse, social worker, behavioral health specialist, pharmacist are all in the room together. Now, that would be hugely expensive if we didn't have the offset, which is many patients, especially young millennial patients, all they're interested in is getting advice and having a question answered. And so they're replacing some of the 15-minute visits on that end of the spectrum with quick texting or tracking their hemoglobin A1Cs on their cell phone and transmitting it to their physician, or there are apps that are looking at tracking moods or anything, and then transmitting that data to the practice, where anybody in the practice can be assigned to take care of that. So I haven't seen huge increases in cost. If anything, I've seen reallocation, and I think it's really, so far, I think a really good solution.
Thanks very much for that, Maureen. And I see in the chat box that Jill Vickerman from the British Medical Association and our very own Angelina Foster, our Chief Executive here at Healthcare Improvement Scotland, have already been sparked to have some ideas about how we could use quality improvement to bring managers and healthcare professionals, doctors in particular in this instance, together. They're already creating their driver diagram in the back of your talk today. So we'll look forward.
Great. You have to send it to me.
Okay, we'll get that sent on to you. Now, Maureen, we have one final question from Michael Kellett from the Quality Unit here in Scottish Government, and Jennifer's going to read that out to you.
Hi Maureen. So Michael's put a really good question forward, and it's just asking, could you say a little bit more about the redesigning measurements leg of the 4 priorities of the Leadership Alliance's work?
Sure.
Yeah, does that get into the balance between data for improvement and data for performance or scrutiny?
Yes, so it's a great question. We're focusing on data for improvement, and we're looking at how can we create a simple scorecard that allows a leadership team to understand where they are. And we're looking at things that we're crossing some of the boundaries that we hadn't before. So in my experience, most healthcare hospital teams, as an example, are not really focused on looking at some of the public health metrics, but how can we create a simple scorecard that allows them to see beyond the walls into the community, but they're not overwhelmed with 500 different little metrics. So we're looking at a very high-level way to look at the health and healthcare offered in a particular community, and that's really, I think, stimulated by the whole notion of an ACO or an accountable care organization. In some ways, the United States is catching up with all of your countries, and perhaps in other ways we're pushing some of the boundaries. So I can't help but think that IHI's motto of all teach, all learn has never been more important than it is today.
Wonderful, Maureen. Thanks very much for that. Now, it's come to nearing the top of the hour, and we'd just like to thank you, Maureen, for the most wonderful talk. This was the busiest chat box we've ever had on QI Connect, and we'll follow up with any outstanding questions. I'd like to thank everyone for those questions. A big shout out to Michelle again. Thank you very much, Michelle, for your wonderful and inspiring starting question. Just to remind everyone that we're having a summer break next month, so no QI Connect. I can see you all deflating on that, but you can look forward to our speaker in September. We are changing the speaker in September. Unfortunately, our speaker has had to pull out of September, but we'll get a great speaker, and we'll let you know that in due course. And also just to flag up that Paul Batalden, we've changed the time of Paul's talk in October, so please mark that in your calendars. We've changed the date on that, and we've already had some fascinating discussions with Paul about his talk. That will be another blow your socks off talk for 2015. And as we come to the top of the hour, just to remind everyone that please tweet about what you've heard. Tweet the link to the recordings. We'd like to see more people using those recordings. And just to say thank you once again to everyone for joining us in this episode of QI Connect. Enjoy the rest of your day.